Hello, everyone. Welcome to our fifth seminar in the Health Terminology and Interoperability Standards seminar series. I'm delighted today to have Debbie Pinter, Debbie Onus, and Laurelie Lawson with us. My name's Linda Bird. Most of you have met me, but for those who haven't, I'm an adjunct assistant professor here at the University of Victoria, and I'm the instructor of HIMP 597, which is the field project in health informatics, and we're hosting this seminar series. So welcome, everyone. Before we get started, we'd like to acknowledge and respect the Lekwungen, Songhees, and Coseps and Esquimalt peoples on whose territory the university stands, and the Lekwungen and WSÁNEĆ peoples whose historical relationships with the land continue to this day. So, as I said, today is seminar 5 in our Health Terminology and Interoperability Standards seminar series. And we have the three wonderful presenters with us today to tell us about the Better Health Record at Alberta Health Services. So, after today's seminar, we have a few weeks break when the students will be doing their own internal presentations. And then on July 30, we have a presentation by Dan Desmond and Charlene from Connected Services in British Columbia to come and talk to us about health information standards in BC. Please note that all of these presentations in the series are recorded and will be shared on the school's website. So if this seminar series interests you, excuse me, then you may be interested in turning your interest into a qualification by enrolling in the Certificate in Health Terminology and Interoperability Standards. Excuse me. This is a one-year part-time program with 4 graduate level courses, including this one, which are done through weekly online evening classes plus a virtual workshop. This is the only program in Canada that's accredited by CHIMA, the Canadian College of Health Information Management, to become a certified terminology standard specialist. So if you haven't already enrolled, then you can enroll in our January entry by October the 1st. So scan the QR code or visit uvic.ca/HIMF and then click on certificates. And so first up today, we have Debbie Pinter with us. Debbie Pinter is the Clinical Operations Informatics Officer, or COIO, for Connect Care Alberta Health Services. Debbie is an accomplished nursing professional, healthcare leader, and clinical informatics expert with over 20 years of experience supporting the delivery of high-quality care through the implementation of clinical and corporate systems. She holds a Master's of Continuing Education, a Bachelor of Nursing, and a Bachelor of Zoology, all from the University of Calgary, and has completed the Alberta Health Services Executive Education Program through the University of Alberta. Throughout her career, Debbie has led large-scale transformation initiatives with a strong emphasis on collaboration, integrity, and practical innovation. Her ability to build trusted relationships, develop effective change strategies, and foster team engagement has been instrumental in supporting the successful adoption of major systems such as Connect Care. In her current role at Alberta Health Services, Debbie serves as the Clinical Operations Informatics Officer for Digital Health. So in this role, she leads care transformation, strategic planning, development, and change management initiatives to support the development and deployment of digital health technologies, including Connect Care, across a variety of clinical settings in Alberta's 4 healthcare organisations. As COIO, Debbie is accountable for the clinical informatics operations team, coordinating all aspects of clinical design, engagement, and adoption for nursing, allied health, and management professional in operations. She also leads readiness, training, and implementation activities and serves as a senior liaison, engaging business, clinical, and IT leaders to present recommendations and facilitate effective problem resolution. Debbie is passionate about supporting teams through change and creating the conditions for successful, sustainable transformations. So we're very lucky to have Debbie with us today. Thank you so much for joining us. I will now pass the floor over to you, Debbie, to present on building a better health records at Alberta Health Services. Over to you.
Thank you. I'm going to share. I just did this. There we go. There's the button. All right. I think everybody has it now. All right. How does that look? Can you all see that?
That's perfect. Thanks, Debbie.
Kind of move the bars around and get rid of that. Okay. Well, thanks for having me again. I think this is my third year doing this talk with you, and so it's great doing this. Third or fourth. We're going to talk a bit about, I do a primer for Debbie, and I'm Debbie Pinter and Debbie Onos. So we have the same first name, but I do a bit of a primer where I'll just really talk about some major or concepts and some of the activities we did from the clinical side of things to do standardization when we implemented our electronic health record or in digital health. And then Debbie's going to take it over and get right into the good stuff around the terminologies and all of the other pieces. So we're going to talk a bit about Alberta's refocused healthcare. I just have one slide so everybody knows we look a little bit different than we did last year. We'll look at Connect Care, which was our big project that we implemented a new provincial electronic health record. Talk a bit about clinical informatics and where we are as a program coming out of that project. How we look at clinical content standards and workflows from that nursing allied health or operations lens. And you know what? You cannot get away from doing a presentation if you don't have something about artificial intelligence. And AI in our electronic health record environments is really going to challenge us going forward. It's a different way to document, it's a different way to do work. And we're going to see if it's going to impact standards or what it looks like kind of in the next 1 to 2 to 3 years. So I threw some slides in there because there's a lot of considerations going forward around how do you standardize and ensure that you have consistency from a clinical lens when you're implementing AI. And then other considerations, we really here emphasize user satisfaction in our tools and technologies, and we do a lot of work to survey our staff and just get some good, useful information to do improvements. And then open it up for questions. I think, Linda, are we doing questions after this and then or are we going to wait to the very end for all the questions?
It's completely up to you, but I'm happy to do questions at the end of your presentation if
Okay,
you like.
perfect. All right, thanks. All right, so as you know, Alberta's been refocusing and we've refocused. I think we are probably done, I hope anyway. But you never know, there's always some stuff that might happen. This just wanted to really articulate, we do have a new, oh, that should be state, sorry, future state. We do have a new future state for healthcare. Before we were Alberta Health Services, and now we are, or my portfolio and myself have been, and even Debbie Onos and Laura Lee have been put into health shared services. So Alberta Health Services split out into 4 ministries with 4 organizations: primary care, acute care, Recovery Alberta, which is your addictions and mental health, and then assisted living, which is really your continuing care, assisted living and home care aspects of care. And then underneath, you've just got a whole bunch of things that fall within that, describing the services. And then here we are over here, health shared services. So I think you might be familiar with this concept in BC because some of your organizations have a shared services where they've carved off digital health, HR, payroll, data and analytics to a degree. And so this is where we sit now. We're over here and we just split off December 1st into our own provincial health corporation. And I think it's going okay. It's we've got some challenges and some interesting concepts to go through, and but really I think health shared services, the fact that they did this will help us keep a standardized state. It's going to be, it comes with some more maneuvering, if you like, but it's really good from a lens of we want standardization, we want data, we want consistency. So that's what that looks like. Connect Care was the project that we implemented, and we are done. We finished this project November of 2024, I believe, was our last implementation. So this is great. However, it continues. What we did was acute care, and some of the four organizations will have Connect Care into it, but we did not dive into the community. But we are now looking at how do we expand Connect Care into our community? So, what does it look like in primary care, where you have private primary care physicians? What does it look like in surgical facilities, private surgical facilities? So we're doing a project right now in one of our newest facilities that's opening, where we're implementing our electronic health record there. And so, we were successful in our acute care implementation, and now government is asking questions. Well, can it be expanded? Improving, continuity of care, improving sharing of information, improving care standards or supporting standardized care across multiple settings is where they're going. So this just really describes currently what we have on the system. And we have all of our acute care and addictions and mental health organizations part of primary care, and everything in assisted living except for our private vendors who provide long-term care or home care. We're all across the province. These are practice areas. I won't get into too much detail here, but we're in every clinical setting. We're right from birth all the way to death, if you want to describe it that way. So we're in women's health, uh, labor and delivery, all of acute care sites, medicine, surgery. We're in ambulatory care. We're in population and public health, radiology, pharmacy. So it is a integrated tool that we implemented for Connect Care, and it is across all specialties. We do have primary care. It's a very small subset of that, but we are there. And we've got our electronic health record is Epic, but we have about 600 other tools that bolt on in and around that support digital health technologies and support Epic and other care environments. So values of Connect Care. When we started this project, it was definitely a larger implementation. We have over 140,000 staff and prescribers, nurses, allied health, and operations who use the system, including clerical. And we have a patient portal called My Chart, and we have over 1.4 million users on that. So we are moving ahead with really expanding into the patient space as we've gotten through this project and we're optimizing. So the value is to Albertans who can access their health information. They have consistent experiences across care settings. And now as we move into the four organizations, they'll have the same tool across all four organizations. It's better information for healthcare providers. We can tailor information and we can support the most efficient processes, as you can see in those four organizations. This is an old slide. We probably need to change this. But for Alberta Health Services, when we did this work, we were implementing clinical best practice, accreditation standards. We were improving transitions between departments and sites. We went from over 1,200 systems down to 600 systems, so cost management. And really, it's state-of-the-art technology. It's so exciting to see what we can start to do with the data and the information that we have. For the healthcare system, there's benefits here in that there's consistent information. And if we start to move into the private space, which would be private primary care, private surgeries, facilities, and continuing care facilities, you're just going to see more consistency across the care stream. So information from ED visits can be visible. Information from med-surg hospitalizations will be available to primary care and publicly funded surgical facilities and continuing care, and vice versa. So it's a very interesting proposition. Worries me a little bit when we think of the number of staff we would have on the system and how big it is, but we work very hard to make sure the system doesn't go down. And then really, decrease costs and improved quality of care, which is what got our funding for that project. Before and after, so probably like you've seen in British Columbia when you've standardized some of your electronic health records within organizations. We had a lot of disparate organizations. We didn't have standardized care. We had different kind of devices throughout the organizations. We had 102 computer and other devices, and we didn't use Citrix consistently, so there was a lot of variance there. We operated at a HIMSS level 1 and at best a HIMSS level 3 for some of our users, depending on what city you were located in. After Connect Care, as I mentioned, we have 140,000 users. We're at HIMSS level 6, and I think we can challenge HIMSS level 7. So we're talking about what would that look like. We have about 150,000 computer and other devices that run the system, and Citrix is like our backbone. It provides, our connectivity and our hardware infrastructure. We are everywhere, and that's publicly funded. And we have about 5,000 workflows and content decisions that were made to support this system. And there is about 16 hours of training on average that you have to take to use the system. But we do believe that people they can drive the bus after they've taken their training. So we've seen a huge shift from before to after. Health system capabilities. So when you start to think about what do you even need to consider to standardize, and then all of the data that goes behind there, or the terminologies, or the information, the workflows, we kind of break it down into two buckets: clinical services and clinical operations. Clinical services is your frontline staff. So when we start to think about these buckets of order management, results, clinical documentation, med management, decision supports, personal health management, which is your patient involvement and case management, we came up with standardized workflows, standardized clinical content, and then designed those pieces into our electronic health record for use at the front line. And then the clinical operations is your identity management, really your HIM features, bedding capacity, and counter referrals. There's some of these pieces that aren't quite completed. Referral management is still in varying stages of getting to one solution across the province. But for the most part, I think, this was our template when you start to think about how do you even begin to look at this? What are your capabilities we're designing for? Now that we're out of the project, we look at continuous improvement and break fix. And so it's really making it better. In a project of our size, we were 5 years continuously implementing. We didn't do a lot of improvements. So we're going back. I call it the transition stage. There's usually a 2 to 3 year transition of let's make the system better from when we implemented it 5 years ago. And so you'll see that we have a whole methodology around how to keep improving this, and then thinking about, I'll talk about a bit later, user satisfaction drives improvements. So how are the users of our system adopting it? And we build in processes for ensuring that it's working for the front line. So this is just a little bit about our teams, clinical informatics. There's myself and a chief medical information officer. We're a dyad. And then we work very closely with our IT partners, our HIM partners, and our data and analytics teams as one group under data and digital health. That's kind of our refocused part of our organization. It brought all of us together, and I think it's really a great fit. But from a CMIO and a COIO, Jeremy Thiel is our CMIO, and he oversees prescribers. He supports 13,000 prescribers across the province and about 3,000 medical learners with 600 new staff a year. Clinical operations, myself, allied health, nursing, clerks, aides, all of those other types, operations and management. We have about 125,000 users, and we train up to 12,000 students from 240 post-secondary institutions every year. So we're a big program. And what do we do? Clinical informaticians. We are the middleman between IT and the front line to translate the requirements or the clinical need into an electronic health record, ensuring that we're designing solidly safe digital workflows and inputting appropriate system content that's evidence informed, and it's going to meet the best outcomes for Alberta. Them just functions. We look at user experience, training, support, comms, and best practice. I put that at the top because it is one of the most important things. Is the system working for your frontline staff? Is it making sense? Can they use it? What are their pain points? And how do we optimize that so we can address any concerns that we have from the front lines? Clinical content and workflows, absolutely super important. Documentation, order sets, decision supports, all of those pieces are really, really important to ensure that you've got a solid system that one will meet accreditation standards, it's safe, it provides good decision making information at the point of care and at the right time in care. And then clinical information system, clinical standards, safe, usable, and efficient optimization. That's more of our optimization program when we talk about this, and then in-system reporting and analytics. Data and analytics is always something that is kind of left to the end. And through this optimization, we know we really got to push the use of data upfront and helping to drive decision making. And so there's a lot of work over the next couple of years that's going to be going into this space. Some just examples of clinical informatics and downstream benefits. So this first one, really, emergency department wait times are long. We have clinical informatics team members who engage with clinical staff across multiple specialties. So when we look at emergency wait times, we built CTAS into the system. That's an example. It's a national triaging tool for emergency departments, and everyone across the province uses it in the same way. So the workflows and the clinical content are standardized. So that is something clinical informatics works with the front lines to say, how do we design and build this? And then we work with our IT teams very closely to make that happen. Evidence-based order sets is the next one. And the example here is really the treatment for pneumonia. For all ordering tools, order sets, therapy plans, protocols, we work very closely with the doctors and the nurses to ensure that they are evidence informed and they're giving the proper decision supports that are needed in the care journey. And so pneumonia is just an example. We've done a lot with, I think we have about 500 or 600 order sets in the system. And we've done a lot working with our frontline staffs to make sure that they are optimized. And then accreditation, I've mentioned this quite a bit. We ensure that accreditation requirements are built into the system. And we do an annual review with our accreditation teams because accreditation requirements keep getting updated and changing and improving. And an example of that is preventing pressure ulcers. What's the required documentation? How much do how often do you assess for skin integrity and all of those pieces? And really just focusing on improving outcomes by doing that work. So just a few other things. Patients, shorter wait times, better access to information and healthcare team. Prescribers and clinicians, it's more efficient and informed care processes and better satisfaction. And then from an organizational lens, information to drive quality, safety, and continuous improvement. And if we think about an informatics team, this is what we're looking to do. We're looking to improve from the patient, the prescriber, and the clinicians and the organization lens. All right. Clinical content standards and workflows. So when we start, I kind of described this in capabilities, and you're going to see it again here. It might be a bit of a beamed up, but it is the same idea. When we think about clinical capabilities, we want to look at buckets of work and say, what's the standardized content, clinical content that you want to put in the system. And then from that, you then look at what is the workflow to best support that clinical content. So example would be allergies and problem lists. So documentation of allergies, where does that fit in the documentation pathway, if you like, for a nurse? Well, it's in your admission assessment, right? When you're admitting into an inpatient nursing or an inpatient surgical or medicine unit. Allergies are documented at triage in emergency departments. Problem lists are where the physicians come in and they document their problem lists when they're seeing the patients. So we start to think about clinical content and standards, and we have a team of people, it's called Praxis, and other teams who help look at this information and figure out what is the best content we want to design into our electronic health record. And these are just some examples. What do we do for admission? And what questions do we ask patients when we're looking at admitting? And patients are, for patient identification and encounter management. We also have SOGI standards that we've built into our system. Lab workflows, results management, MedRec and EMAR is such a big piece of ensuring safety for our patients. And how are we building standardized information into support decision making? Orders and protocols, I talked a bit about that. Assessments and progress notes, really the documentation piece. Standardized data sets for outcomes measurement, really focusing this year on dashboards, data, and getting training in place for how to use that information once you have it. And so that's just really the basis of clinical content and workflow. When we're looking at all of this, we have some goals for design and build to reduce the burden and eliminate the duplication. That is a big thing that we hear from staff, or at least if I just look at nursing all the time, the burden of documentation, and prescribers also. Prescribers look at pajama time, and for nursing, it's overtime, but it's the same idea. They're staying after their shift to do documentation. So how can we help eliminate that burden? Evidence-informed best practice. We're always looking for what is the evidence to support anything we design and build. We have a whole group that supports regulatory requirements from a physician, a nursing, and an allied health lens. So we adhere to the professional and regulatory requirements. I'll give you an example. Many of the allied health and the nursing regulatory body CARNA have just put out their AI requirements for safe practice. And so looking at that, how do we start design and build that into the system? We incorporate decision supports. It's an opportunity to support frontline care. And then there's standardized documentation, vocabulary, standardized scale scores and tools, standardized core set of standards. And I think Debbie Onos will go into more of that, those pieces. We focus on collaborative care and patient and family-centered care, and then standardized workflows. So that was, there's principles that support all of this. And we went into, when we started to design out Epic, for example, these were our first and foremost principles that we used to ensure that the system was going to work. Can't do any of this stuff without governance. And I'm just going to flash up a governance slide. You kind of got to always flash up a governance slide. And there's many governance layers behind this slide, but you're only going to be successful if your governance is successful. And we spent a lot of time in the project making sure that governance was well thought out. And then even after the project, moving into operations, we've had to redesign. But what I want to point out is this legend here, 65%, 25, 7, and 3. What this refers to is who is the person making the decisions. So at a health shared services user rep committee, this is where you get CEOs and others from our 4 organizations making decisions. It's only 3%. If we flip it down to the bottom and you start to look at these orange boxes, this is where we are getting frontline staff. And so what's really important here is that the frontline staff have 65% of the decisions, and it's their system. We should be getting them to design and build it for their needs. I talked a little bit about this, maybe just some concepts around success. We talked about our goals, but what does success? Is that whenever we can reduce the burden and we can incorporate evidence into the system and the clinicians say they like it, we're like, yes, we were successful. Less narrative and more data driven supports outcomes measures, and we work really hard to work with our frontline to see what that looks like. Accepted standardized measures is important. Reinforced patient safety, probably should put this one straight to the top. How do you ensure that the system supports patient safety? We have a whole patient safety team, human factors team that constantly looks at our electronic health record from, falls, a pressure ulcers, a barcode management, scanning, BCMA approach. So lots of work goes into that. And then I've added down here, navigating the way that AI will change policy, procedure, and practice. I think that's going to be important for us, and we've started some work on this. Okay, artificial intelligence. I think these are the last few slides. I'm just trying to see. Linda, I have till 6:45, right?
Yes,
Yeah, perfect.
including
Okay,
questions, but yes.
including questions. Okay. So artificial intelligence it's hitting us fast and furious, and it's changing the way that we are looking at our capabilities, if you like, or how to deliver on those capabilities. So I refer to this as a revolution to revolutionary. And I did this slide because I was very interested in all of the industrial and the internet and the cell phone and artificial intelligence. We have all had, we've lived through some sort of big change to our technologies that we use. Probably the most recent everybody's familiar with is the internet, and then, the smartphone. And some of the things that I really want to point on this slide as we move into what is artificial intelligence. Now, AI has been around for a while, but it has not been embedded into an electronic health record. And this is the game changer for our frontline staff in that the speed of spread and how quickly the tools are morphing and being designed, it's like very fast. If you think of industrial revolution, it was decades. If you think of the cell phone, it was years, 10 to 20 years. But when we think of AI and the way that the decision supports and the tools are being developed and then morphed again and again and again to be improved, it's like months. And so when you have this level of rapid change in the way that we're doing our work, we have to kind of repivot and think about, what does this look like? So I think this is just quick. What does the AI do? Well, it learns, it thinks, it improves over time. And thinking, it uses those patterns to make predictions or decisions. It's not like us where we think, it's not human, right? And it supports decision making and helps teams work faster and more safely. And these are all concepts that we are challenging as we implement AI into our electronic health record to say, really, does it do all that we just said it did? But it does not think like a human. It doesn't understand meaning. It doesn't have emotions, doesn't make independent decisions. It doesn't deviate from what it was trained on. And so those are important concepts for frontline staff to know when they're starting to think about, oh, I'm going to do ambient documentation now, or I'm going to use a generative or agentic feature for AI. This is all of the types of AI that are hitting our electronic health record, and we call it the algorithmic on the spectrum of algorithmic intelligence. And it's not all done in the same way, but it displays in different ways to a front line. Robotic processing could just be faxing, automatic faxing, for example. Um, Rule-based logic will be some decision supports that you build in the system where it fires alerts for frontline staff. That's getting smarter, and it's coded more in a way to align with AI principles. Predictive analytics, statistically derived. We have the ability to implement 10 predictive models, and we currently have done early warning, so deteriorating patient, sepsis, patient maybe going into sepsis. We are looking at length of stay for patients, trying to predict length of stay, discharge disposition. So it's statistically derived from a predefined set of data. Generative AI, which is summative AI, artificial intelligence, and it creates summarized information for staff to use. But the agentic is the game changer, where it's planning and it's reasoning and it's providing recommendations and it's doing some of the cool stuff that you see, maybe Copilot and other AI tools on the internet use. And so when you start to think about all of this coming into your electronic health records, it's a big impact for staff. How does it work? I think you guys might know this, but you have historical data in some way. You have a trained model you've developed and a learning method. You put these two together, and over time, it improves and gets better. It becomes adaptive, it becomes predictive, or it summarizes, and then there's an output. But the important part here is this human oversight. You always need the frontline staff to be right on top of this. There's a role that we have to play in advancing AI. How is it used? And as I mean HSS, when to use it, what is it, alignment to any privacy legislation or ethical considerations. We measure our benefits risk, and we ensure education and training is in place for leaders, managers, employees, and we support implementation, adoption, and use. The role of a nurse or allied health and even a prescriber here is to be aware of the tools that they're using, be aware of their regulatory body requirements of them when they are using these tools, to use it in the right place, the right time, and the right setting for the right care. Use it judiciously. It is not going to replace all your other decision support tools that, like your libraries and your articles and all of those pieces. And really critically appraise and validate any AI outputs, because there's always bias and error. It has to learn. You have to make sure it's not hallucinating those things, and you monitor it. So what I mean, this is all going to support standards. New standards development is kind of like we had it working with paper documentation. We got rid of that. We have it working now with electronic documentation, and now we're really shifting how documentation looks in the system. This is just a bit about education. We need to support our staff to use it because it's a change for people. All right, we're in the home stretch here. So other considerations for us is user satisfaction. I think this is really important. We collaborate with an organization called CLOS, and we measure our user satisfaction. CLOS is a standardized benchmarking company. They have 300 healthcare organizations internationally, 400,000 clinicians in 13 countries. So we benchmark against the user experience score. They ask a series of questions. There's 11 metrics, and then there's a lot more for this, but then they use these 11 metrics to calculate a satisfaction score for their staff, and that falls in, there's kind of three buckets. They put all of their, what is your EHR education, what's your governance, and what's your personalization, which means how involved are the staff in designing and building and using the system. And so these are the successes that they give recommendations on. We did a survey in 2023, and then again a survey in 2025. We were coming out of the project in 23, so there was a lot of blips and satisfaction wasn't great. It sat around organizationally at 14.7, but we got it up 2 years to 22.3. Really good satisfaction is sitting in the 40s to the 50s. Surprisingly, I would think 70s, 80s, but when you're getting into 70s, those are the organizations that are doing it really, really well. And there's some exemplars across the world. Saudi Arabia is a good example. They're in the 70s and 80s with their user satisfaction. So we measure this, and we're going to go into another survey in 2027 to see if we've made some improvements. We take the recommendations and the clinical comments from these surveys and put it back into our optimization. And this is just a breakdown of the different staff and where we're at. Nurses, for example, sit around 19.9, allied health 28.9. The doctors made huge improvements. They were negative, came up to a 0.6. So it's really important that we look at these pieces. Okay, that's it. Wanted to leave at least a few minutes for questions.
Thank you so much, Debbie. It's great to see your progress each year. Alberta is one of the forerunners in terms of health information standards usage across Canada, so it's wonderful to have you here. Does anyone have any questions for Debbie Pinter?